Good morning, everyone. So, many individuals present with the complex scenario of bleeding and thrombosis simultaneously. So, one of the scenario is the portal vein thrombosis and acute variceal bleeding. So, in the next 25 minutes or so, I will first discuss about the type of PVT and risk of varices and variceal bleeding, and then have a few case-based scenarios. So, portal vein thrombosis may be acute, it may be chronic, or it may be tumor related. And type of portal vein thrombosis has the variable risk of variceal bleeding depending on the presence of severity of liver disease and the duration of thrombosis. So the risk of variceal bleeding is mainly localized to the patient with cirrhosis with pre-existing portal hypertension, pre-existing varices. And in patients with acute PVT in non-cirrhotic liver, they are mostly symptomatic. As you can see in this patient, live patient which we see in our OPD, this patient was symptomatic. Almost 90% of these patients are symptomatic with pain abdomen, with the risk of bowel ischemia, and early initiation of anticoagulation therapy in these patients prevent the development of dreaded complications like bowel ischemia, and also prevent the progression of thrombosis. And in those patients who fail to achieve the recanalization of the thrombosis, the studies have shown that the risk of esophageal varices development is at the rate of 50% at the end of 2 years, and 5% of patients bleed at the end of 2 years. Now come to the different scenario, the acute or recent PVT in a patient with cirrhotic liver. Most of these patients are asymptomatic because of the presence of the extensive portosystemic collaterals in these patients and the decreased amount of the portal blood flow. So most of the patients have no major consequences in these individuals, and the pain abdomen is very uncommon. However, some of the patients may have the exacerbation of the portal hypertension. As you can see here, the increase in the portal pressures in some of the patients, almost 30% of the patients, may lead to development of esophageal variceal bleeding, and some of the patient development of ascites. Now, the symptoms of acute PVT in cirrhotic liver not only depends on the severity and the presence of portal hypertension, but also the extent of thrombosis. As you can see here, the more extensive the thrombus, the complete thrombosis and the extension of the thrombosis to the SMV and the splenic vein lead to decreased chances of recanalization with the anticoagulation therapy. And moreover, the relationship of the vessel occlusion and the flow rate is not linear. You can see here, in almost, if the 50% occlusion of the portal vein is there, the decrease in the blood flow is almost 80%. So even with the 50% decrease in the lumen diameter, the thrombosis, the flow rate is very low, and almost 98.4% decrease portal flow is there if the occlusion is 80%. So partial PVT is also lead to high risk of decreased portal blood flow. Now the 1/3 of the patient with portal vein thrombosis have underlying cirrhosis, and the PVT in cirrhosis is different. And it is not only the higher incidence and prevalence of PVT in patients with cirrhosis, especially in those patients with advanced cirrhosis, because the thrombophilic factors are plays a lower role, but more commonly it is mainly due to the altered hemodynamics, the decreased portal blood flow, which is common in patients with advanced cirrhosis, which is the main trigger of the PVT in patients with cirrhosis. Now come to the other type of PVT and the risk of variceal bleeding, the chronic PVT. The chronic non-cirrhotic PVT, which we see, one of the major example is the EHPVO, which lead to development of the portal cavernoma. The risk of variceal bleeding is high. Almost 90 to 95% of the patients develop varices. Many patients develop ectopic varices, and there is a development of portal cavernoma in these patients, which is classical of PVT, EHPVO. Then the chronic PVT in patient with cirrhosis is generally very difficult to recanalize with the help of anticoagulation therapy, and it has also some consequences like development of portosystemic shunts, development of gastric varices, and it may complicate the transplant procedure, and some of the patients develop portal vein calcification, as you can see here in the diagram, after a while. Then the other type of PVT is the tumoral PVT. The variceal bleeding may be aggravated by the portal vein tumoral thrombosis in a patient with SCC. The studies have shown that the 2.6% higher risk of acute variceal bleeding in patients who had tumoral PVT as compared to the SCC patient with no PVT. Moreover, the newer therapies of SCC, like the immunotherapy with the bevacizumab and the atezolizumab, increases the risk of the variceal bleeding further. Now second part of my presentation is the case-based scenario. Now this is the first case, a 41-year-old male, alcohol-related compensated cirrhosis. He had no previous PVT, now detected to have recent non-tumoral PVT, and on endoscopy found to have large esophageal varices. So important question arises in this case. Does the recent PVT increase the risk of rupture of esophageal varices? What should be choice of primary variceal bleed prophylaxis, whether we should non-selective beta blocker or EVL or combination therapy? How safe and effective are anticoagulants in the presence of the large esophageal varices with or without EVL? And what is the best time to start the anticoagulation therapy? Should be the type of anticoagulation therapy and the duration of the therapy? Now coming to the each answers one by one. This is the large longitudinal study which have studied mainly the patient with compensated cirrhosis and portal vein thrombosis, and this study has shown that the development of PVT is not associated with the risk of progression of decompensation, progression of liver disease, including the no major increase in the risk of variceal bleeding. However, the more recent study have shown that this patient with cirrhosis and acute recent PVT, more than 2/3 of the patient had recent PVT. Those patients who had PVT had the higher risk of portal hypertensive related complications, including the variceal bleed and the ascites. They postulated that most likely in the higher complication is due to exacerbation of the portal hypertension and leading to acute decompensation in these patients. Now, what should be the primary prophylaxis in presence of the PVT and the large esophageal varices? The systemic review and meta-analysis of the retrospective and the prospective studies have shown that in patients with PVT, there is a 4-fold decrease portal vein velocity with the use of beta blocker therapy, and the beta blocker therapy might promote the PVT development and progression. So efficacy of the non-selective beta blocker in the setting of the PVT is not adequately studied. Moreover, the studies have shown that the median time of variceal eradication after the EVL is higher in patients with PVT as compared to patients those who have no PVT. But after the variceal eradication, there is no influence of PVT on the varices recurrence. Now, many clinicians are obviously not comfortable with using the anticoagulation therapy in patient presence of the high-risk esophageal varices, the so-called the coagulopathy-related bleeding, which are common in patients with advanced cirrhosis. Moreover, there are reports of the portal vein thrombosis that can aggravate the variceal bleeding after the endotherapy. The more recent studies have shown that the anticoagulation therapy or the treatment referred to PVT reduce the incidence of the acute variceal bleeding after the endotherapy. So this is the meta-analysis of the studies investigating the variceal bleeding according to the anticoagulation therapy, and this study had beautifully shown that the anticoagulation therapy reduces the risk of variceal bleeding in patients with PVT. In this study, they had used the low molecular weight heparin, which was effective in the PVT resolution and was associated with the lower risk of variceal bleeding. The timing of anticoagulation therapy is the most important while starting the anticoagulation in presence of PVT, and this study showed the predictors of the radiological response to anticoagulation therapy in cirrhosis with PVT. What they found that the only risk factor for the poor radiological response was the delay in the initiation of the anticoagulation therapy. So when planning to start the anticoagulation therapy, it should be started as early as possible within 2 weeks of the diagnosis, and the delay in the diagnosis leads to the poor radiological response and high risk of development of chronic PVT. Now, how to start the anticoagulation? What should be the type, duration? And initial anticoagulation should be low molecular weight heparin or the directly acting agents, mainly in child A and child B cirrhosis. In child C cirrhosis, the data is not that robust, and they should be first line. The first line options may be dabigatran or rivaroxaban. In patients with renal failure, the unfractionated heparin is better as compared to low molecular weight heparin. In severe thrombocytopenia, fondaparinux is always better. And due to advanced cirrhosis, there is a low antithrombin level, so efficacy of the low molecular weight heparin is somewhat decreased in patients with advanced cirrhosis. We should not use the warfarin or acetrom as a first line therapy because of the high risk of bleeding with the use of warfarin, and moreover the INR monitoring is required with the warfarin, which is fallacious in patients with advanced cirrhosis. When using the Clexane, we should keep the watch on the platelet count and monitor for the heparin-induced thrombocytopenia. We should avoid the L-Thrombopac for PVT because it is prothrombotic. And the INR, it is important that there is no prophylactic correction should be done to correct the INR. Now coming to the case 2. This is the patient with cirrhosis with recent portal vein thrombosis and presenting now with acute variceal bleed. He had MELD score of 16 and a mild ascites, and the door to scope time was 3 hours, and patient was adequately managed with terlipressin injection and the endotherapy with large esophageal varices. EVL was done, bleeding was stopped. Now the important question arises after the initial hemostasis. Does the acute recent PVT increase the risk of rebleeding, and do we need the additional therapy to prevent the rebleed? When to start the anticoagulation therapy after the acute variceal bleed and after the endotherapy? What should be rescue therapies in such scenarios if in case he rebleed? And long-term response to anticoagulants on preventing the rebleed and portal vein recanalization. Now I will come to these scenarios one by one. So the studies have shown that in patient with acute variceal bleed, the portal vein thrombosis is an independent risk factor for 5 days poor control of bleeding. Those patients with PVT had baseline had the 3 times higher risk of 5-day failure to control bleeding. And the more recent studies have shown that not only 5 days rate of bleeding control, but the higher chances of 14 days and 6 weeks rebleeding in patients after EVL in those patients who had portal vein thrombosis. So PVT in acute anticoagulation should be started in patient with PVT as early as possible after the control of acute variceal bleeding. And the studies have shown that those patients who are on anticoagulation versus those who are not on anticoagulation, there is no difference in terms of the plasma requirement, blood transfusion, ICU admission, active bleeding, or 5-day control of the bleeding. So after the control of bleeding can be safely started without any major risk factor for rebleeding. However, this patient rebled at 5 days, and there was a large post-EVL ulcer in this patient, and the second endotherapy was failed, and we rescued this patient with Denisella stent. So what next option, definite option in this patient? So this patient underwent within 8 hours very early salvage tips was done in this patient from our IR lab. And during the TIPS procedure, the stent was placed, and the suction thrombectomy was done, and the one unit of urokinase was injected, and the patient was there was no rebleed thereafter. Now the TIPS is better, or the repeated EVL plus propranolol is better. This randomized study was done in 2018 for preventing the variceal rebleed in patient with cirrhosis with portal hypertension. They did the TIPS procedure within 6 weeks of variceal bleeding and used the 8 mm stent, and the local urokinase was given for 3 days in patient with occlusive PVT, extending to SMV and the splenic vein. And they had shown that the risk of rebleeding at the end of 1 year and 2 years was much lower with the use of the TIPS as compared to the EVL plus propranolol. Moreover, the portal vein recanalization was achieved much higher rate in patient with TIPS as compared to EVL plus propranolol. What we can see that the very high rate of portal vein recanalization, very early portal vein recanalization, almost at the end of 2 months to 3 months, almost 80% of the patient developed the portal vein recanalization in this patient. So the management of PVT in cirrhosis need a closer look, and the TIPS should be done in patients who fail to achieve the recanalization within 6 months of the anticoagulation therapy, or patients who have as a first line TIPS should be done in patients who have the extensive thrombosis extended to the complete to the splenic vein or SMV, or who are more symptomatic. So the main issue with cirrhosis with PVT using TIPS is the feasibility of the TIPS, because the portal vein is already blocked. So there are ways to achieve this, and the studies have shown that the 80 to 90% the patients can achieve the TIPS procedure. If the intrahepatic portal vein is visualized, then the intrahepatic vein should be cannulated. Otherwise, the alternative procedure may be through the transsplenic route may be achieved to develop TIPS. Some of the studies have shown that if the large collateral is there, then we can put the TIPS in TIPS stent with one end at the one of the large collateral may be there, and the studies have shown that even in the presence of the portal cavernoma, which is common in EHPVO, the TIPS procedure has been done successfully. The other advantage of the TIPS is that it facilitates the local thrombus resolution, like the local thrombolysis, thrombectomy, and it also facilitates the gastric varices embolization in many of the patients. Then this study presented in ASLD had shown that the recanalization rate was much higher in TIPS procedure, almost 90%, as compared to anticoagulation therapy, 77%. And recanalization of PVT is largely related to the hemodynamic effects of the re-established portal vein vein. And after the TIPS procedure, because the vein is opened up, so the flow will increase and there is no need for anticoagulation therapy in most of the patients, and patient may become portal vein, there is no risk of rethrombosis in most of the patients even without the anticoagulation therapy. This is a study done at the ILBS, which had shown that in patient with persistent PVT for 6 months, despite the anticoagulation therapy, use of TIPS is highly effective. It achieved the complete portal vein recanalization rate of almost at the end tune of 80%. Now, TIPS is not always effective. Some of the patients with large tumor burden, so large thrombus burden, so TIPS may be inadequate, and these patients with massive thrombus extension to the SMV or the systemic, like whole system is occluded, so TIPS may not be effective in some patients. So this is a randomized study which was done in patients with cirrhosis and acute PVT. What they did that initially give the systemic urokinase therapy through the SMA route, and then it loosen up the clots, and then after that the TIPS is done, then it may achieve the better recanalization rate. So generally, if the SMV and the splenic vein recanalization is better achieved, combination of urokinase plus TIPS. So in our patient, the portal vein recanalization, we can as shown in this ultrasound Doppler, was achieved at the end of 12 weeks. Now this was about the portal vein recanalization and the control of bleeding, but anticoagulation therapy was improved survival in patient with cirrhosis and portal vein thrombosis. This is the meta-analysis of the 5 studies, including the 500 patients with cirrhosis and PVT. Anticoagulation therapy reduces the all-cause mortality and independent of thrombosis severity and recanalization. Anticoagulation therapy not only clears out the large thrombus, but also the microthrombus, which are common in patients with advanced cirrhosis. So these are few caveats of using the long-term anticoagulation therapy for acute PVT in cirrhosis. The median time of PVT resolution is around 5 to 8 months. Less chances of recanalization with anticoagulation therapy after 6 months. We should do TIPS in these patients. If PVT recanalization rate is almost 40% complete and partial is 63%. And predictors of poor portal vein thrombosis recanalization are the extensive PVT, involving the SMV and the splenic vein, the patients who had the advanced portal hypertension features like ascites, the delay in the initiation of the anticoagulation therapy, and the JAK2 mutation positive. Almost 30% of the patients develop rethrombosis after starting the anticoagulation. The median time of rethrombosis is early after the stopping anticoagulation. Median time is 1.3 months. And it is important to remember that the recanalization is not always equal to prevention of decompensation. So these are my concluding slides. The acute PVT and the acute variceal bleeding, most likely underlying cirrhosis is there. The non-cirrhotic, it is very unlikely to have acute variceal bleeding. In before acute variceal bleeding, start anticoagulation early, within 2 weeks. Safely in the presence of varices, it reduces varices risk and rebleeds. Prefer the long-term DOACs or the low molecular heparin because it achieves the better portal vein recanalization and the survival. EVL is not contraindicated in presence of varices on anticoagulant therapy. After the endoscopic hemostasis, restart the anticoagulation as early as possible, and TIPS is superior to EVL plus non-selective beta blocker in cirrhosis with PVT after the control of acute variceal bleeding, because it not only prevents the variceal rebleed but also achieves the better recanalization and probably the better survival rates. Thank you for the kind attention, please.